So the first modality with which we can treat benign prostatic hypertrophy is medical management. And medical management is of two types. I'm sure Dr. Ranjan has covered this in great detail. I will just highlight the salient points which you should remember from the surgery point of view. So you have two types of medicines here. You have alpha 1A blockers and you have 5-alpha reductase inhibitors. The alpha 1A blockers are tamsulosin and alfuzosin, and these are selective alpha 1A blockers which relax the smooth muscle tone. They relax smooth muscle tone, and when they relax the smooth muscle tone, they lead to a quick onset of action and relief of symptoms. So quick onset of action is there with alpha 1A blockers, as they release the smooth muscle tone. And which component will they act on? I told you there are two components. So this acts on the dynamic component of benign prostatic hypertrophy. Now, alpha 1A blockers, you know the side effects of alpha 1A blockers are postural hypertension, and first dose hypotension. But because we are using selective alpha 1A blockers, these side effects are less as compared to non-selective alpha blockers. The 5-alpha reductase inhibitors, I told you 5-alpha reductase is the enzyme which converts testosterone to the dihydrotestosterone, which is the active form. And it inhibits, these drugs inhibit this enzyme. So the examples are finasteride and dutasteride. They have slow onset of action. So their action is going to take weeks to months to show effect, whereas alpha 1A blockers will show their effect in a few days. But there is a more sustained action. There's a more sustained action with 5-alpha reductase inhibitors, and this acts on the static component, that is the hyperplasia part. And it has been seen that this can lead to a 50% reduction in PSA, and it can lead to 20 to 30% reduction. It can lead to 20 to 30% reduction in volume over a period of 6 months. So in 6 months' time, this is the effect which 5-alpha reductase inhibitors can show. Now, one significant point here, one practical point is, because this causes a reduction in 50% reduction in PSA, so any patient who's on 5-alpha reductase inhibitors, the PSA, the actual PSA is 2 times the value which you measure, because it is causing a 50% reduction. So you should assess the PSA value carefully in these patients. Now, when I have to start medical management, it obviously makes sense to combine both of them, because alpha 1A are acting faster and 5-alpha reductase are acting slowly. And more importantly, both of them are acting on separate components. So the best medical management is combination therapy. So this was regarding the medical management. The surgical management, you should first know what are the indications to carry out surgery. These indications have been asked in various exams. The most important indication is involvement of upper urinary tracts, involvement or hydronephrosis. Patient not responding to medicines. If there is any acute or chronic retention, I have already spoken about chronic retention with you as well. Acute or chronic retention of urine is there. If there are multiple episodes of if there are multiple episodes of urinary tract infection, or if there is one episode of gross hematuria, there is gross hematuria. And this I remember because my grandfather, now touchwood, he is 92 years old, fully active. And when I was in my second year of post-graduation, that's when he developed gross hematuria and he was diagnosed with benign prostatic hypertrophy, and we had to get a TURP done. So I never forget this indication because I've actually practically seen it happening. The other indications are if there are bladder diverticulae which have developed, if there are bladder diverticulae which have developed, or stones which have developed because of back pressure changes, and if the flow rate is less than 10 milliliters per second and pressure is more than 80 centimeters of water. These are the various indications to carry out surgery in benign prostatic hypertrophy. So what are the surgeries which are done for prostate? I've told you the most commonly done surgery is TURP. TURP stands for transurethral resection of prostate. And transurethral resection of prostate or surgical management of prostate is the one which can give rise to more than 75% improvement. More than 75% improvement in the International Prostate Symptom Score. And after doing a TURP, there can be an increase in flow rate by 9 to 18 milliliters per second. These are direct lines out of Smith Urology and Bailey, that more than 75% improvement in prostate score and the flow rate increases by 9 to 18 milliliters per second after doing surgical management or TURP. The other surgeries which can be done are HoLEP. This is holmium laser enucleation of prostate. This is holmium laser enucleation of prostate, and lasers are now being used, and holmium laser specifically, this is hemostatic. This is hemostatic, and faster surgery can be done. Faster surgery can be done using lasers, and it does not penetrate deep. It does not penetrate deep. Okay. Another one is called TULIP. TULIP stands for transurethral. TULIP stands for transurethral laser incision of prostate. Transurethral laser incision of prostate is TULIP. Another point which I want you to know, that open surgery is usually not done now. Open surgery has virtually been replaced by TURP and HoLEP. So we don't do open surgery. I just want you to know about retropubic. Retropubic approach is known as the Millens approach. The retropubic approach for prostatectomy is known as the Millens approach. It is no longer done, largely been replaced by HoLEP or TURP. But again, my father, who's a pediatrician, I have his Bailey as well, and I've read that also. And in that, there is a lot of mention about open prostatectomies and the major complications related to it. And with TURP coming in, the complication risks and the morbidity has significantly reduced, even in large size glands. Now, before I explain you the details of how this procedure is done and what are the complications, let me just briefly mention about the lasers which are used, because they have also revolutionized this surgery. The most commonly used laser is the holmium YAG laser, which is used. But the best laser for prostatic surgery is the KTPA green light laser. This is 532 nanometers wavelength, and again this laser is hemostatic, and because this laser is hemostatic, this can even be used in patients on anticoagulants. So that is one advantage, that even if the patient is on blood thinners or anticoagulants, you can use the KTPA grain light laser, and it leads to faster surgery. Faster surgery, there's less blood loss and less complications when lasers are being used. Now, what exactly is done in TURP? Like I told you, this is the urethra. This is the bladder neck, right? So this is your bladder neck. And we discussed that the bladder neck is the one which is preventing the retrograde ejaculation. The muscles there here are the ones which close and they prevent retrograde ejaculation. This is your prostate and the prostatic urethra. This is the prostatic urethra and the prostate which is there. And this is the verumontanum. Verumontanum is a bulge just distal to the prostatic urethra. And distal to the verumontanum, you have the sphincter. Okay. So in TURP, what is done? In TURP, we are going to go through the urethra. I go through the urethra using a resectoscope, which I'll show you in the video. And when we go through here, we will start cutting off chips of prostate, right? We start cutting off chips of prostate, and we keep on delivering them outside. But what happens that when we do TURP, the bladder neck is rendered incompetent. That is why very high rate of retrograde ejaculation is there. There is very high rate of retrograde ejaculation in these patients because the bladder neck is rendered incompetent. And the other thing which I told you, this verumontanum will be my distal limit of resection, because I don't want to come distal to this. Otherwise, I can damage the sphincter. Otherwise, the sphincter can get damaged. Okay. Now, while doing this surgery, again you will see in the video that to get a clear field of vision, I want a clear field of vision so I can see properly. So we use irrigating fluids. During surgery so that we get a clear field of vision. And the irrigating fluids which can be used are 5% dextrose, distilled water. Both these are hypotonic solutions. Isotonic glycine can be used. Usually 1.5% glycine is used, or normal saline can be used. Right? So these are the irrigating fluids which can be used. Now, hypotonic solutions, that is 5% dextrose and distilled water, were associated with increased incidence of TURP syndrome, which I will talk about in the complications. That is why their usage has reduced. Isotonic glycine nowadays is the most commonly used solution because of the less incidence of TURP syndrome or dilutional hyponatremia with isotonic glycine. Normal saline, one question has been asked 2 or 3 times in the exam. Normal saline can only be used if bipolar cautery is present. Remember, we've discussed monopolar and bipolar cautery, so it can only be used in BTURP. BTURP means when bipolar TURP is being done, that's when normal saline can be used. When monopolar cautery is being used, we don't use normal saline because it does not conduct the current properly. It does not help in good conduction, and proper cutting does not happen. That is why it is only used when bipolar TURP is being done. So these are the points which I want you to remember. Now let me show you an operative video with which things will become much more clearer. Whatever factual information I've told you, let's just put it to practical usage so you'll understand that, and then we'll talk about the complications. So this is the operative video of TURP, and you can see the resectoscope. This resectoscope is the instrument which is used to carry out TURP, and it is inserted through the penis into the urethra. Now you can see the narrowing of the lumen, and you can see the verumontanum which just came into view. Now with this resectoscope, now you can see that the urologist starts cutting chips of prostate, right? This video has been shared by Dr. Raman Tanwar, who is the Marrow SS Urology faculty. Now you can see that he's cutting out chips of prostate, and as he's doing that, the lumen is opening up. So these are the chips of prostate which are being cut out, and wherever there is bleeding, you coagulate those areas. I spoke to you about the irrigation fluid. That is of utmost importance because we want a clear field of vision, right? You can see this is the verumontanum which just came into view again. So this is how prostatic chips are cut and then they are delivered outside. So like you saw in the operative video that before surgery there was narrowing of the lumen, but after surgery the lumen opens up once you do the TURP and those prostatic chips when they are cut. Now it is very important to talk about the complications of TURP because lots and lots of questions have been asked regarding the complications of TURP. So the complications of TURP, the first one is hemorrhage. And hemorrhage is the most common complication which occurs during surgery, right? So during surgery, hemorrhage can occur. And this hemorrhage is because of two arteries. So you have the Badenoch arteries and you have the Floch arteries. Now, the Badenoch arteries are the ones which are situated at 5 and 7 o'clock. These are the larger arteries, and these are branches of inferior vesical artery. These are the branches of inferior vesical artery, and these are the arteries which bleed most commonly during TURP. So this question has also been asked. These are the vessels which bleed most commonly during TURP. These are the Badenoch arteries. That is why prophylactic coagulation is done at 5 and 7 o'clock. The Floch arteries are the smaller arteries and they are situated at 10 o'clock. Right, Floch arteries are the smaller arteries and they are situated at 10 o'clock. These are also branches of the inferior vesical artery. So these are the vessels which can bleed. That is the first complication which I wanted you to know about. The second complication is clot retention. So because some amount of bleeding can occur in the post-operative period as well, a clot can block the Foley's catheter. And as I was telling you that we were in a ward which did a lot of TURPs, so a very frequent call which we used to get from the nurse or the intern at night was that the catheter is blocked and we had to come and then flush the catheter, remove the blockade so that the patient could be comfortable. Now to prevent this clot retention, we put in a three-way Foley's, right? We put in a three-way Foley's. I've already shown you what a three-way Foley's is in the bladder module, where one of the channels is used for irrigation, and after surgery a continuous irrigation is continued so that clots don't form. Usually the Foley's is removed on day 3 to day 4 after TURP. That's when the Foley's catheter is removed. So that was regarding a clot retention. The third complication which I want you to know, which is very important from the point of view of the exam, and majority of the questions have been asked from this, is TURP syndrome or dilutional hyponatremia or water intoxication right? So let me explain to you why does this TURP syndrome develop, and then we will discuss the details regarding the management as well. So during TURP, this is the urethra where we are operating. This is the urethra, and you have seen that the blood vessels are adjacent to it. These are the blood vessels which are there. Now, in the urethra, supposing we are using distilled water as the irrigating fluid, distilled water, you know, is hypotonic. And in the blood vessels, you have blood flowing. Blood, you know, is isotonic. Right? Now, as the surgery proceeds, the fluid will move, water will move from which direction to which direction? Will it move from the blood vessels to the urethra or from the urethra to the blood vessels? Yes, correct. So it will move from, water is going to move from the urethra to the blood vessels. So as the surgery proceeds, the water moves from urethra to blood vessels. And how much water moves? So it is usually 20 milliliters per minute is the movement which occurs. And the approximate duration of the surgery is 50 minutes. So therefore, approximately 1 liter of water can move in from the urethral compartment into the vascular compartment. Okay, so this is how much fluid can move in, and this is provided if the height of the irrigation fluid means at what height you hang the irrigation fluid during TURP. The ideal height is 60 centimeters. So this is what happens at 60 centimeters. But if it is increased to 70 centimeters, or it is made higher, then more fluid shift will happen. Right? So that is why the height at which you hang the irrigation fluid is also very important. Okay, so what is happening that before surgery, the value of sodium in blood is X and the blood volume is Y. After surgery, what has happened? That the value of sodium has remained X only because we haven't added any sodium or removed any sodium. But what has happened to the volume of blood? There has been addition of more fluid. So blood volume expands. So Y has increased. After surgery, Y has increased. And this is what gives rise to dilutional hyponatremia. Okay, so dilutional hyponatremia, this is how it occurs. What are the clinical features of dilutional hyponatremia? The patient, a few hours after surgery, patient will come with altered mental sensorium, will have headache, nausea and vomiting. These are the clinical features. Now, up till now, in my career, I've just seen one patient, and that too not in the surgery ward, but in the gynae ward actually. A gynecologist was doing a difficult hysteroscopy, and the hysteroscopy went on for a very long duration. And post that, the lady developed dilutional hyponatremia. So that's the only place where I have seen this happening, not in the surgery or the urology ward. So these are the clinical features with which the patient will present. And invariably, if the intern calls us that this is what is happening to the patient, that 4 to 6 hours after surgery, the patient is developing these features, then we tell them to immediately send serum electrolytes to see the value of sodium. And how do we manage these patients? So management is if the sodium value is less than 120 milliequivalents per liter, then it is severe hyponatremia. And these patients with less than 120 milliequivalents per liter, they require 3% hypertonic saline. These patients require 3% hypertonic saline infusion. Now, this has to be done very gradually because not more than not more than 8 milliequivalents per liter per day correction should be done. Right, not more than 8 milliequivalents per liter per day correction should be done. So gradual correction should be done. This I'm sure Dr. Rakesh has also taught you. Gradual correction should be done. And the reason for this is, if rapid correction is done, then it can cause central pontine demyelinosis or central pontine myelinolysis. Now, this is where a lot of students get confused. Both the things mean the same thing. Demyelinosis or myelinolysis, it means the same thing. It's just an interplay of English. And sometimes in the question, students get confused. So please don't get confused here. So gradual correction has to be done. Now, if the sodium value is more than 120 milliequivalents per liter, then the only thing which we require is fluid restriction. We give less fluids in these patients. And how will that help? How will fluid restriction help? So fluid restriction, how will it help is that you see that there is excess volume here. Now, if I restrict the fluid, the body will gradually throw out this excess volume and it will return back to the normal state. So that's how fluid restriction helps. So as we were discussing that TURP syndrome or dilutional hyponatremia was higher when distilled water and 5% dextrose were being used because these were hypotonic. But the incidence has reduced. Incidence has reduced with the use of isotonic glycine. So the incidence has reduced with the use of isotonic glycine, which is why glycine is the preferred irrigation solution these days. But one of the problems, and that is the next complication, is glycine toxicity. So glycine toxicity can be there. So glycine toxicity is if more than 500 cc of glycine gets absorbed. If more than 500 cc of glycine gets absorbed, it can increase the risk of myocardial infarctions, right? It can increase the risk of anginal pain and myocardial infarction. So that is glycine toxicity, which is why it is very important that the duration of surgery is restricted, right? So faster surgery with the use of lasers has reduced the incidence of TURP syndrome also and the incidence of glycine toxicity as well. Okay, that is the advantage of using lasers. The next complication is retrograde ejaculation. Now, retrograde ejaculation, I've told you, occurs because the bladder neck is rendered incompetent, and this is the most common complication following TURP. This question has been asked many a times in the exam, and in one of the exams they also asked the incidence, that is 60 to 75% is the incidence of retrograde ejaculation. Incontinence can occur if we go beyond verumontanum. This point also I've discussed in great detail. If we go beyond verumontanum, then the incidence of incontinence following this surgery will go up. There can be a urethral stricture which can occur in the long run, urethral stricture. And the most common site for urethral stricture, the most common site is the bladder neck. This question has also been asked. And another question which has been asked in the INI-CET and the super specialty exam is that if a large resectoscope is used, if you don't calibrate the size properly, if a large resectoscope is used, then it can give rise to meatal stenosis as well. Then it can give rise to meatal stenosis as well. Also, patients following TURP, they might require a reoperation as well. And the incidence of reoperation, as mentioned in Bailey, is 5 to 15%. So as high as 5 to 15% patients might require a reoperation. So these are the various complications following TURP which you should know about. Complications following TURP is a short note for final year students, and lots of MCQs have also been asked. With this, we come to the end of the management of BPH, where I've told you about medical and surgical management both. Let's now talk about prostate cancer. That is the other condition which we wanted to discuss. But before I tell you about prostate cancer, I also want you to know about the PIRAD scoring. Do you remember the BIRAD scoring in breast, which was breast imaging, reporting and data systems? Similarly, PIRADS is prostate imaging, reporting and data systems. So it tells us how suspicious a prostatic lesion is. And this is usually reported on an MRI, and PIRADS 1 is very low, 2 is low, 3 is intermediate, 4 is high, and 5 is very high, which tells us that the lesion might be cancerous. Moving on to prostate cancer now. So prostate cancer, the risk factors for prostate cancers are increasing age. Now this is a very interesting risk factor because in Bailey it is written that if a male reaches the age of 90 years, then there is a 90% chance that he is harboring a foci of prostate cancer, right? So as the age increases, the risk of prostate cancer also increases. Increased testosterone, very high incidence in African American males, African American population. BRCA2 gene more common than BRCA1 gene. In the breast module, I told you that the BRCA gene can increase the risk of prostate cancer, and BRCA2 more than BRCA1 is also a risk factor. Obesity is also one of the risk factors for prostate cancer. You should know the most common gene which is mutated in prostate cancer is the GSTP1 gene. This is the most commonly mutated gene in prostate cancer. Prostate cancer is one of the cancers where screening is carried out, and screening for prostate cancer starts at 50 years of age. At 50 years of age, screening is started, and there are 3 modalities. You have DRE, that is digital rectal examination. You have prostate specific antigen, or there is a combination of DRE and prostate specific antigen, and this is the best modality. This is the best modality which is there, and it is done on an annual basis starting from 50 years of age. So DRE plus PSA is the best modality. This question has also been asked multiple times in the exam. Now we've already discussed the symptoms of prostate cancer, and we've discussed the workup as well. So we know for a fact that the diagnosis will be confirmed by, so if we talk about the investigations, the investigation of choice for prostate cancer is a truss-guided true-cut biopsy. Truss-guided true-cut biopsy or transrectal ultrasound-guided true-cut biopsy is how we will make the diagnosis. You should also know that MPMRI, what is this? This is multi-parametric prostatic MRI. Multi-parametric prostatic MRI. This tells us about the local stage of the disease. This tells us about the T stage or the local stage of the disease. It will also tell me about the lymph node status. This is also used for evaluation of recurrence, and multiparametric MRI now is also used for follow-up of prostate cancer patients. So that is the utility of a multiparametric MRI which you should know about. Also, you should know the spread of prostate cancer. The reason why I'm discussing the spread, because one of the modalities, the investigative modalities, is related to this. So it can either be local spread, where it can involve the seminal vesicles, or it can involve the rectum, or it can be lymphatic spread. And you should know that obturator lymph nodes are the first lymph nodes to be involved. First lymph node to be involved. For all urological malignancies, you should know which is the first lymph node which is getting involved. So here it is the obturator lymph node. And distant metastasis, the most common site is to the bones. And if you remember your module on breast cancer, I've covered in detail about breast and prostate, both going most commonly to the bones. And which bones? They go to the vertebral column. Why the vertebral column? Because of the Batson's plexus of valveless veins. Which vertebrae? So commonly involve the lumbar vertebrae. And what type of bony metastasis is seen? So in prostate cancer, you know osteoblastic is more common than osteolytic. Whereas in breast cancer, osteolytic metastasis was more common than osteoblastic. So all these questions are very, very important. All of these are very important for the exam. Now, the modality which I wanted to talk about was a bone scan. Bone scan is done to see if there is any bony metastasis or not. And this is done if PSA is more than 10 nanograms per milliliter, or if Gleason's score, this is another term which I will talk about, very, very important for the exam, if Gleason's score is 7 or more, or if the patient is symptomatic, that means complaining of backache or bone pain, that is when we will carry out a bone scan. And this is what a bone scan looks like. This bone scan will survey all the bony structures, and if there is a metastasis, it is going to appear as blackish deposits on the bone scan. So wherever you will see a blackish deposits in the bone, that means there is cancer there, or bony metastasis is present. So these were the investigations in a patient with prostate cancer. Now, when a biopsy is done in a patient with prostate cancer, we always calculate the Gleason's score. The Gleason scoring is extremely important. And let me just briefly tell you what is Gleason's score. Then I will tell you the details. So, prostate cancer is an adenocarcinoma. But it is heterogeneous in nature. Right? So there can be different types of gland formation in one part of the prostate cancer, but different types of gland formation in another part of the prostate cancer. Right? So when the pathologist sees the slides, she will see multiple types of these gland formations. So what they do is, they see the most commonly occurring gland type, and they see the second most commonly occurring gland type. Okay. And for each gland type, they give a score from 1 to 5. Now, of course, the details have been covered by Dr. Ila in her pathology slides, so I'm not going to cover the pathological details, but just as a layman, I can tell you that 1 means that there is well differentiated glands, and 5 means there is poorly differentiated glands. Right? Details, of course, you can refer to the pathology modules. So 1 is well differentiated, 5 is poorly differentiated. And when you add these two up, that's when you get the Gleason score. So the minimum Gleason's is going to be 2 and the maximum Gleason's is 10. And higher the Gleason score, poorer the prognosis. So higher the Gleason's, poorer the prognosis. So you can see in this table, this is the traditional Gleason scoring and these are the new groupings. And here the gland types have also been mentioned here. So just another table which depicts the same thing. So a low Gleason's is grade group 1, which is a Gleason score of 6 or less than 6. These two are very important, intermediate favorable and intermediate unfavorable. So intermediate favorable is grade group 2, that is Gleason's of 7, and unfavorable is also Gleason's of 7. Now you might be confused that how come 7 is being given a favorable also and unfavorable also. So favorable is when it is 3 plus 4 and unfavorable is when it is 4 plus 3. How come? 3 plus 4 means that the most commonly occurring gland type is 3 here and it is 4 here. So the most commonly occurring gland type, because it is better differentiated in this category, that is why it has a better prognosis. And the difference is so stark that they have had to classify it into two separate groups. So please remember this, 3 plus 4 has better prognosis than 4 plus 3. High is grade group 4 and 5, that means Gleason's of 8 or 9 or 10. Those are the high risk groups. So we follow the TNM staging for prostate cancer, and this is the T stage. So for prostate cancer, for your PG exam, even if you just remember the T stage, that is good enough. Although it's not been asked in any exam as a staging, but it's good to remember the T stage. Tx is when the tumor cannot be assessed. T0 is when there's no evidence of tumor. T1 is very interesting. So T1 is something which is extremely new and exclusive to prostate. T1A is when it is an incidental diagnosis where you do a TURP, and when you identify the TURP specimen, you find that less than 5% of the tissue has prostate cancer. That means, remember I showed you that video where those chips were being removed? Those chips are sent for pathology. If the pathologist says that less than 5% of them incidentally have prostate cancer, then it is T1A. T1B is when it is more than 5%, and T1C is when it is a screen detected cancer which is detected because of increased PSA. T2 is when it is confined to the prostate. When one lobe is involved, it is T2A, or both the lobes are involved, it is then T2C. T3 is when it involves the seminal vesicles, that is T3B, and extracapsular extension is T3A. T4 is when the adjacent structures are involved, that is the rectum or the bladder neck or the pelvic muscles. That becomes T4 disease. There is also an old staging classification known as the Jewish and the Whitmore classification. This is another staging classification for prostate which is no longer used now, the Jewish and the Whitmore classification. Also, there are two prognostic tables or scores which you should know about. So you have the Partin's tables. There are Partin's tables, and you have the D'Amico score. Both of these tell us about the risk of recurrence. Both these scoring systems are prognostic scores, and they tell us about the risk of recurrence. And what is included in the Partin's tables and the D'Amico score, what is included is the Gleason scoring, the PSA, and the stage of the patient. So what is included in the Partin's or the D'Amico score is the Gleason scoring, the PSA, and the stage of the patient, and they tell us about the risk of a recurrence. Now, moving on to the management of prostate cancer. So the treatment of prostate cancer, I'm going to divide prostate cancer into early prostate cancer, into locally advanced prostate cancer, and metastatic prostate cancer. And that is how we approach the treatment as well. So early prostate cancer is T1 or T2A, T1 or T2A disease, that is early prostate cancer. And if there is early prostate cancer, we divide these patients into two groups. These are divided into, the first group is the group which is less than 70 years of age. These are fit patients who are less than 70 years of age, which have either a G3, G4, G5 grade, so a high grade, or the Gleason score is 7 or more than 7, and the life expectancy for these patients, the life expectancy is more than 10 years. Is 10 years. So this is group 1. Group 2 is those who are more than 70 years, where the life expectancy is less than 10 years of life expectancy is left, or it is G1, G2 disease. So the reason why we are splitting them into two groups is that this group goes for observation or surveillance. No treatment is given to this group. Observation or surveillance is what is done. Whereas this group, which is the fitter group and has more aggressive disease, this goes for radical prostatectomy. This goes for radical prostatectomy. Now you might ask that why is there this difference between the two groups? When they have the same stage of the disease, why differentiate between them? So the reason for that is that these T1 or T2A tumors, they have slow progression. They have slow progression, right? And it has been seen that these patients who have favorable disease and less life expectancy, they are more likely to die of other causes, maybe the heart condition or other comorbid conditions, rather than the prostate cancer, right? So that is why this group is not unnecessarily subjected to aggressive surgery or treatment. Right? So it's not as if we don't like them. We like them equally, but it's just that because of the slow progression of the disease, we observe these patients and it's usually been seen that they'll die because of other causes. This group, which is the fitter group and has more aggressive disease, goes in for radical prostatectomy. Now the problem with radical prostatectomy is that it was a very morbid procedure. It's a very morbid procedure, lots of complications associated with it. But with the advent of robotic surgery, and if you remember your module on minimally invasive surgery, I told you that robotic surgery, one of the prime uses is robotic radical prostatectomy. So that is what is being done these days. We do robotic radical prostatectomy. Robotic radical prostatectomy, or another name for this is RALP. RALP is robot assisted laparoscopic prostatectomy. Laparoscopic prostatectomy. And these days, what are we doing? We are doing a nerve preserving RALP. These nerves are the cavernous nerves, which you remember I told you in the anatomy. These cavernous nerves are responsible for erection and they are present in the posterior part of the capsule. So while doing this robotic laparoscopic prostatectomy, we are careful that we don't injure these nerves and then the patient does not have erectile problems. So we try to save these nerves. Okay. Now, what exactly is removed in radical prostatectomy? So, what is removed is the prostate till the external sphincter. Till the external sphincter. That means the prostatic urethra as well. The seminal vesicles are also removed. And then the urethra is anastomosed to bladder neck. Then the urethra is anastomosed to the bladder neck, and we also do lymph node removal. So that is what is removed in radical prostatectomy. The major complications of radical prostatectomy are sepsis, incontinence, erectile problems. These are the major complications. I've told you to prevent the erectile problems, we are doing a nerve-preserving radical prostatectomy. So this was the management for early prostate cancer, where one group gets observation, the other group gets laparoscopic or robotic radical prostatectomy. Now, if we talk about locally advanced prostate cancer, so this is T2B, T3, T4, and lymph node involvement can be there. So that is your locally advanced prostate cancer. Again, the two groups. Group number 1 is those who are less than 70 years, those who have more than 10 years lifespan left, or have aggressive G3, G4, G5 disease. And the other group is more than 70 years, who have less than 10 years of lifespan, and they have G1, G2 disease. So these patients who are the favorable group, they are going to receive radiotherapy plus minus androgen deprivation therapy. ADT is androgen deprivation therapy or hormonal therapy. Why? Because remember I told you that it is testosterone which is giving rise to this cancer, and it is also fueling the cancer. It is the one which is acting like petrol for this cancer. So if I can block that testosterone, I can stunt the growth of this cancer, right? So these patients will get radiotherapy plus minus androgen deprivation therapy. Whereas these patients who have the aggressive disease, they will first get radiotherapy. So radiotherapy for prostate, I will tell you, is of two types, either IMRT or brachytherapy. I'll tell you about that in a minute. So once these patients receive radiotherapy, if there is good response, these patients are put on androgen deprivation therapy. But if residual disease is still left, then they will go in for robotic radical prostatectomy. Then we have to carry out radical prostatectomy in this subgroup of patients. Okay. So like I was telling you, radiotherapy for prostate can be either IMRT. Right. So IMRT is intensity modulated radiotherapy. And we give almost 76 to 86 grays of radiotherapy, which is one of the highest in the body. That amount of radiation is given in prostate. The other one is brachytherapy. Brachytherapy means where we directly implant electrodes. You can see here that directly radioactive wires or radioactive seeds are directly put into the prostate. That is brachytherapy. And here we can either use iodine 125 or we can use palladium 103 for brachytherapy in prostate cancer. And brachytherapy works very well in these locally advanced prostate cancer patients to shrink the disease. So this was regarding locally advanced prostate cancer, and it has been seen that majority of these locally advanced breast cancers will develop metastasis in 3 to 5 years. So almost 50 to 60% of these locally advanced prostate cancer patients will develop metastasis in 3 to 5 years. Finally, coming to metastatic prostate cancer. Metastatic prostate cancer, when there is distant metastasis, it has been seen that the median survival The median survival is 3 to 3.5 years for patients with metastatic prostate cancer. Now, how do we manage patients with metastatic prostate cancer? The first line of treatment for metastatic prostate cancer is androgen deprivation therapy. That means we have to reduce the testosterone level. And this androgen deprivation therapy can be done either by the surgical method, that is surgical castration or bilateral orchidectomy, which can be either subcapsular. And the first year MCH resident who joins a urology MCH, this is the main surgery which he does in the first year. And even final year students, when they're posted in the urology department, they also get to do a lot of bilateral orchidectomies because it is the cheaper alternative to remove both the testes, and that acts as hormonal therapy. Medical management. Medical castration can also be done, and medical castration we can use LHRH analogs. LHRH analogs can be used, like goserelin. Goserelin goes with the trade name of Zoladex, or buserelin can be used. Now goserelin comes as 1 monthly, 3 month or 6 month depot injections. So we give these injections and they can last for 1 month, 3 months or 6 months. So the patient can choose and get these injections. One more is a Degarelix. A Degarelix is an LHRH antagonist which can be used for the treatment of metastatic prostate cancer as well. Now, if we are using LHRH analogs like Zoladex or goserelin, which is most commonly used, in these patients we need to combine it with anti-androgens. We need to combine them with anti-androgens. The anti-androgens being either flutamide or enzalutamide, which comes with the trade name of Xtandi, or abiraterone, which comes with the trade name of Zytiga. Now, you might wonder that why are we adding anti-androgens? And the answer to this lies in the physiology of the negative feedback mechanism. Now, I'm sure Dr. Krishna Kumar has taught you that whenever you give these LHRH analogs, they will first go, and for the first few days, for the first 10 days or so, there will be a transient increase. There will be a transient spike in testosterone. There is a transient spike in testosterone, and then the values will start falling. So because there is this transient spike, this can give rise to a PSA flare in the first few days of treatment. And to prevent the PSA flare, we combine them with anti-androgens. Okay? So this is the first line of treatment. We start the patient on androgen deprivation therapy. But what happens is that after a few years, the tumor becomes hormone resistant. And when the tumor becomes hormone resistant, what are the treatment options which we have then? Then we can either give these patients chemotherapy. Chemotherapy can be in the form of paclitaxel or cabazitaxel. Or these patients can be given a T-cell vaccine, and this has also been asked in the exam. This T-cell vaccine is known as Siplusil T. And it is a CD54 extract. Which is created individualized to the patient. So this is used in hormone resistant tumors. This has been asked as well. Or if there is hormone resistant bony metastasis, Then we can use radiopharmaceutical therapy. And for radiopharmaceutical therapy, we can either use strontium 89 or we can use radium 223, which acts via alpha rays. So this has also been asked. Radium 223 acts via alpha rays. Whereas if you remember your thyroid module, we discussed about iodine 131 and that acts via beta rays. Okay, so this is for hormone resistant bony metastasis. So this was the treatment for prostate cancer. This is how you should remember it: early, locally advanced and metastatic. And that is how clinical questions will be framed. Now, to end this module, please remember the most important prognostic factor for prostate cancer. The most important prognostic factor is the stage of the disease. And you should also know that PSA, prostate specific antigen, is used as a tumor marker, and this can identify recurrences, right? So we track the PSA when the patient is kept in follow-up, and if we see that the PSA is rising, that can be the earliest sign that there is a recurrence which is happening. So this is regarding prostate cancer. So for final year students, this module, the points which are important are TURP can come as a short note. Complications of TURP has been asked in the exam as a short note. And majority of the times what has been asked is TURP syndrome or dilutional hyponatremia comes as a short note. So you should prepare these for your final year exams. Now before we end this module, let's quickly do a few MCQs to just recapitulate the entire module. All of the following are lower urinary tract symptoms except. So sudden urge to urinate is, enuresis or nocturnal enuresis is there, dribbling when the patient is asked to lie supine and asked to cough is there. Incontinence during intercourse is not a lower urinary tract symptom. This was an INI CET exam question which was asked. A patient is being planned for truss-guided true-cut biopsy and you are asked to perform it. How many cores are to be taken while performing this procedure? We have discussed that minimum 12 cores have to be taken when we are doing a truss-guided true-cut biopsy. Now a treatment-related question. You have a 75-year-old man with prostate cancer who comes to you with a PSA of 9 with small tumor focus. His Gleason's is 6. What will be your management in these patients? Right? So this patient is more than 70 years. He has a favorable Gleason's score. So this falls in the observation or surveillance category. Early cancer where there is favorable prognosis, patient comes in the surveillance category. Now this is something which summarizes the workup of a patient with lower urinary tract symptoms. I've told you the workup. Let's answer these questions and decide what is the next treatment option for these patients. Okay. So you have a 56-year-old male who has increased frequency of micturition and narrow stream. Means this patient has lower urinary tract symptoms. Ultrasound shows an enlarged prostate. So prostate is enlarged. PSA is 2. Prostate specific antigen is 2. So it's low PSA. So we don't need to do biopsy. Here we can straight away start the patient on BPH management because the patient has features of BPH but PSA is not raised. 62-year-old male with fever, pelvic pain, dysuria, enlarged prostate is there. Examination shows pus cells. So this is a patient with prostatitis. So here we are going to give antibiotics and repeat PSA after 6 weeks. 67-year-old man with back pain, DRE shows a hard prostate. PSA is 22. So hard prostate, PSA is 22. We have to carry out a truss-guided biopsy. 59-year-old man with lower urinary tract symptoms, PSA is 6. I told you if the PSA is more than 3, we have to carry out a biopsy. We have to carry out a biopsy in these patients. So the final question, which of the following substances is not used as an irrigant during classic monopolar TURP? So I told you monopolar TURP, we can use glycine, we can use dextrose, we can use distilled water. Normal saline is only used when there is bipolar TURP. So these are the questions regarding this module. Please remember, prostate cancer is a very, very important module. So go through it with great care, and especially with the next exam coming in, you might get multiple questions from prostate module. Thank you.